This is the RxGenius podcast, where we discuss better healthcare with the professionals who are making healthcare better. Hosted by pharmacist and epidemiologist Paul Liabenow, the show dives into the science, strategy, and real-world stories shaping modern medicine.
Thank you for joining us on another podcast with the RxGenius. I am your host, Paul Liabenow, and we have an incredible guest for you today. But before that, I want to just address the topic, something that I don't normally do, but we're going to talk about sexual health today. And I think it's a really important topic, first off, but I think that I don't usually get an opportunity to kind of give my opinion, right? And so with that said, what I'd like to say is that sexual health isn't just about avoiding disease. It's not just about unwanted pregnancy. It's not just about planning. It's about respect, right? It's about consent. It's about well-being. It means knowing your body, understanding your boundaries, and feeling safe with your choices. It's okay to ask questions and speak up. And so today, we're going to talk to an expert to do just that. So with that said, Dr. Nadia, thank you so much for being on with us.
Thank you so much for having me. It's great to be here. I love this podcast and this concept overall. This is excellent.
No, yeah, thank you for I know that Todd, our producer, was really wanting to get you back on a podcast. And so he was super excited that you responded to my direct message on Instagram. So we're super thankful for that. I want to get a little bit about your background. So, what I always tell our audiences is that, what's most important about our conversations is the people that are having them. So tell us a little bit about yourself.
Yeah, so I'm a licensed pharmacist. I started out in retail, and then I went into the compounding world where I did a lot of hormone replacement therapy, low libido medications, and it got me talking more to people about sexual health and wellness. I also got certified as a sexual health. It's a sexual health therapy certification program I did, but I consider myself a sexual health coach. So now, fast forward, I work as a clinical pharmacist for a mail order company, and then I also do my own practice with sexual health coaching for patients. So I kind of do a little bit of different things. It keeps my life interesting, and I really feel like having, like you were saying, really great, meaningful conversations is very rewarding for me.
Yeah, I appreciate that. And honestly, that's really what this podcast is about, is nothing grandiose, nothing targeted specifically. It's just about what can we have a conversation about? How can we how can we get to the point of a particular matter? And obviously, as we have ebbed and flowed over the course of what has been like the last decade, sexual health has, some of that stigma has it's gone away. It's not as, things are not as taboo as they once were, but there's still issues that prevail, both from a disease perspective as well as from a well-being perspective. So I think that there's a lot of things that we can talk about, but I have a few pillar questions that I think are important that I'd like for you to answer. And I think it's going to give us an opportunity to kind of go off in tangents and talk about some really interesting things this evening. But when we talk about sexual health, the first thing that comes to mind, right, when people are asking these questions is, what is the most common misconceptions patients have about sexually transmitted infection, prevention, and treatment? When people come to you, when people are in a position where they do have an STI, STD, and they do need service, what is the biggest misconception that you run into?
The biggest misconception that I've seen with patients is that they think no symptoms equals no infection, no STI. And so, there are sexually transmitted infections that are asymptomatic, such as chlamydia, gonorrhea. That's a common one. And a lot of them can be have no symptoms. Some of them do. So people often think, well, if I don't have symptoms, I don't have anything. And then the frequency of how often they should get tested. I know you've done a lot of work with HIV treatment and management. And that's one where, if you think you've been exposed, if you get tested the next day, it's not necessarily going to come up as a positive test. So that's the biggest one as far as misconceptions go. With STIs that I've seen that are very common.
Yeah, I mean, I think that it's really important to have a conversation, especially as people kind of come of age, right? Mm-hmm. I think that, being able to, we don't live in this world where abstinence is a conversation anymore. And if it is, it's not a conversation that I'm hearing. So, I mean, when it comes to education, what do you think is the most important thing as folks come of age that they need to be educated about?
I think as far as education goes, I will say it is great. I've seen a lot more commercials that talk about sexually transmitted infections, that talk about treatment, especially for the HIV prevention treatments. And I think that it's just the most important thing is for people to just talk about it and be comfortable talking about it and be able to talk about it and know who to talk to. Everyone's going on TikTok for advice, and you have to know your source. So that's the big one. Know who you're talking to. Googling symptoms, as we know, is not always the best thing to do either. So it's important to know what questions to ask and who to ask them to. Those are the two biggest takeaways, I think, as far as what people need to do now.
Yeah, I think that it's really important for folks to recognize that there is a void in the educational process. I mean, I think that people don't recognize still that we do live in a world where, I'm not going to say conservatism, because I don't think that that's what it is. I think that there's just a lack of understanding as it relates to how the conversation should play itself out. I mean, I don't know what your experience was growing up, but I know mine was very traditional. It was very conservative. It was very apropos. It was 100% taboo to have any type of conversation about sex. And how I learned about sex was in an unhealthy way. So it wasn't sexually healthy, right? So I learned the hard way, and unfortunately experienced some of the consequences of not having the education that maybe some others had. And so I think that we take for granted that the 21st century has presented this great opportunity with social media and more education and more government funding, when at the end of the day is that there is a massive population of children and young adults and adolescents that are not getting the type of education that's necessary for them to be successful with their sexual health.
Mm-hmm. Yeah, no, absolutely. I agree with that. I mean, I've seen there's just a lot of new things that are out too, and people just don't know what questions to ask. Another one that I've seen a lot of, I specialize a lot in female sexual health, because I feel like for so long it was just not talked about for women. Things weren't researched properly. Things weren't talked about as far as menopause in general, perimenopause, post-menopause, menopause. What are the different signs and symptoms? What are the tests you can do? And so a big passion of mine has been to educate women on that also, and their sexual health, because it's just, I still think we have a long way to go. But we are getting there for sure.
Yeah, I think the perimenopause is a huge issue. I think that unfortunately, well, I know in my home we are experiencing that, and by we I don't mean me. And so my partner is experiencing that, and and she's a doctor of integrative medicine, and she is learning about herself for a second, third, fourth, and fifth time, right? And so I think that it's really important to be able to have that conversation early on to say, these changes are going to happen. This is about sexuality. This is about your identity. This is about a lot of things that bring you into the world in a different way. And I don't think, like, for me, the hormonal pharmacist is another one that I follow. I don't know if you're familiar with the hormonal pharmacist that talks a lot about menopause and those types of things, and does a really great job of being, of educating kind of the audience, the social media audience. But again, I don't think that, when it comes to, I'll put it to you this way, there is so much opportunity for us to provide clinical resources at the pharmacy, whether it's behind the bench or whether it's in a drug counseling type of setting. And I think that, even with Mango Health, right? Yes, we do behavioral health, but we do a lot of sexual health, and we're having a lot of conversation about how sexual health is in direct relation to mental health, recovery, all of these types of things. And so it's such an intertwined aspect of life that, unfortunately, we miss out on an opportunity clinically to be able to provide that service. And I don't know why that is all the time, because I feel like at Mango Health, like, that's 99.9% of what we do is clinical. Like, the management, the operational just seems like a default. And so when we're working with patients and clients, we have this kind of intimate opportunity to kind of round out the educational process and really bring people into the situation so that they can take ownership for their health, whether it's sexual, whether it's recovery, whether it's mental, whatever it might be. So, another question that I have for you that I want you to kind of shed some light on is, how do you think social stigma and cultural attitudes impact patient access to sexual health medications, like, today? Like, again, and I think it's to my point of, like, there is a whole population out there that is still living in the 1950s. Even in 2025, what do you see, in your practice that still kind of reeks of social stigma and cultural attitudes that are getting in the way of people having the sexual health that's necessary for them to be successful?
Yeah. So, I've seen patients who are in their, 50 plus, I would say. And so they're a whole different conversation than patients that I see in their 20s and 30s. The older patients are a little more hesitant to talk about sexual health most of the time. And that's because of it being something that was not really talked about in the past, or it wasn't, it was more hush hush. As far as younger people, it really depends, but I've seen a lot with different religions and religious upbringings, cultural beliefs, where in certain households, it's not something that you talk about. So there's that also. And so it really is a case by case basis, but I'm seeing more of the younger population feeling more open to talk about it. But it's still 50-50 with depending on their upbringing. And it really depends on what it is. A lot of women still don't feel comfortable enough to talk about orgasm, and anything like that. Men have a lot easier time, I find, talking about it. And that's because of socially, we've talked about it more. We came out with male enhancement drugs. Viagra was the first one. So it's been talked about for much longer. So that's what I've seen.
Yeah, I know. Yeah, I mean, I know that in behavioral health, we ask a lot of questions around sexual health as it relates to behavior. Obviously behavioral health, that's the question that we're asking, but, is trying to, go beyond, okay, you are diagnosed with HIV, or you, now you're living with HIV, or we'll talk about PEP and PrEP in a second, and some of the upticks in disease states as a result of PEP and PrEP, which is super interesting. But we do something super interesting. We call it a sexual inventory, and it really is, especially in addiction treatment, we have to ask ourselves, did we hurt anybody? Did we hurt ourselves? Do we put ourselves in positions that could have hurt others or ourselves? How do we view our sexuality? Questions that we've never asked ourselves before because we've been using drugs or alcohol to basically cope with life, and therefore have not really discovered what it looks like to have a healthy sexual identity. It's interesting because, you know, when we go through a sexual inventory in a behavioral health setting, it opens up the door for a lot of other questions to be asked as well as answered. And, you know, I think that what we find is that, you know, we can take care of whatever it is. If you come into a treatment center, whether it's mental health or addiction treatment center, and you've got anything from chlamydia to hep C, we have a solution for that, right? Like, we know what that solution is. But there's this whole other arc of what was my experience, you know, as a result of my mental health disorder or my addiction that has harmed myself or others. And so super interesting to be able to have that conversation within the context of social stigma and cultural attitudes, because everyone comes in differently as it relates to, like you said, everybody comes in differently as it relates to their comfort level about how they're going to talk about it and how they're going to discover what sexuality looks for them as, in this case, a sober person, right? And so, you know, we try to figure out how we can treat the whole person and bring all the clinicians in alignment together to be able to say, yeah, we'll get you on your pepper prep, we'll get you taken care of with the Z-Pack, we'll get you on Havarni, I mean, whatever it might be. Don't worry about that. But let's talk about the deeper issue is that, you know, what was causing the behavior that ultimately put you at risk in the first place, and how can we prevent that from happening in the future?
Yeah, and there's often trauma related with it. I've dealt with a lot of patients where it's not just a libido issue. There is some type of trauma that's happened. So I'll work with I always refer them out to a psychotherapist or whatever they need. And I'll also follow up with that clinician because like you're saying, you have to get to the root of where it's coming from. And it may not just be libido. It may be because of some type of traumatic event that happened with the patient. I've seen that very often. And a lot of times it's something they didn't even think was trauma, but it is, you know, right. So that's very interesting.
In many cases, it's something that was trauma that they were told was not trauma. That was not traumatic, right? And we see that all the time, you know. And I am pretty open about my experience. I am a person that's in recovery, and you know, I went through this whole many years ago, went through this whole process myself, you know, to be able to kind of identify who I was going to be as a sober human being. And sexual health was a huge piece of that, right? Like, how was I going to respect myself and respect others now that I wasn't operating in a world where there was no respect whatsoever, right? So important to be able to have these conversations and to ultimately get to a place where, and we'll go back to below all of the attempts at being healthy in every area of our life is a behavior that is attached to it, right? And for as much as that is obvious, it is not obvious, right, to the patient or client. So if it's sexual health or mental health or gut health, I just had a conversation with a pharmacist about the gut microbiome and how that impacts a myriad of things in your life. It's important for us to have that conversation because it goes to this idea that I think that when we are sexually healthy and we have a healthy sexual identity, then that is representative in many cases of what's going on both externally and internally, meaning we're surrounding ourselves with healthy people and we're treating ourselves in a healthy manner and doing a lot of things right, in my opinion.
Yeah, absolutely.
So let's move on a little bit. I want to talk to you about what we see in the sexual health category of new medications, things that are kind of on the horizon, things that are being worked on, what is working now, what isn't maybe working, and maybe something that's not working. It's not because the drug isn't, blockbuster and amazing. It's that, we don't have the resources to be able to get it in the right hands. Mm-hmm. But what's your opinion?
Yeah. So the most promising ones that I see are the ones that I've seen for hypoactive sexual desire disorder in females. So basically low libido in females. Vyleesi is the brand name. So this peptide therapy, bremelanotide, I always mispronounce it, but Vyleesi is one of them. It was the first FDA approved peptide used for that. Another one is Veozah, which is for hot flashes in women who are going through menopause. Those are two big ones. I really want to see more. And it's unfortunate because I see a million commercials for the PrEP and PEP, all the HIV. I think that's amazing that we have all those commercials, but we don't really see anything for women's health, for like menopause, for any of this. I have seen maybe here and there of Vyleesi or Veozah, but we need more to get that out there more. And then hormone replacement therapy for women also. They're working more on that. In the beginning, they'd put a Band-Aid on low libido in women and they'd give them an antidepressant, and specifically in the SSRI category, which ironically can lower sex drive. So I thought that was interesting. They would say, oh, well, you're depressed, so let's give them an antidepressant so they'll feel better. But is that really making them feel better? What's the real cause of this? Is it hormonal? So I'm glad that we're getting more away from doing that, because that wasn't the answer, and that we're looking more into peptide therapy and treatment of symptoms of menopause. And and then we are looking more at perimenopause. I've seen that talked about more. So, I myself am in my 40s, and you start experiencing that. And there really is no way to test it levels wise for blood work. It's not an easy one like in men where it's low testosterone. It's symptom based. So it's, if you're going through it based on your symptoms. So I'm liking seeing more talked about that, and the new hot flash treatment. That's good. So I'm seeing more of that too. So I've been happy about that also.
So what's the strategy to do better? I think that it's interesting that you bring up the idea of prescribing an SSRI and then that being problematic, which it obviously is, and it should be well known on the street, not just your doctor. Yeah. Which sometimes I don't know that that's always relevant for a doctor, because I think that, quite frankly, it's set, in many settings, right? In primary care specifically, it's very sexist, right? Yeah. Where the male doctor is writing off a symptom of a female patient when something genuinely is going on. And it comes back to this: I know my body, I know something's happening. Don't tell me I need Prozac, right? Yeah. And I've heard that time and time again. So I'm like, what would you say is the best version of being able to make sure that from a medical practice perspective, we're moving away from that? I mean, yes, we can, I suppose, diminish the authority of certain doctors that have not stepped into the 21st century. But beyond that, what does it look like?
Yeah, I think, the first piece of that is media, seeing more commercials about it. I recently saw a commercial. I thought this was pretty cool, about how the forceps used in the gynecological equipment used in office was designed by a male. So it was this horrible metal piece of equipment as far as like to do the pelvic exam and the pap smear. And they've come out with one that's more comfortable and flexible for women now to be used in the office. And they actually had a commercial about it. And I was like, that's really cool. I'm really glad they did that, because, we need to see more things like that. And then social media, I follow some social media accounts. I'm reading some books out there about menopause. So the more we can get it out, I think the best outlet for all of this is definitely social media. So the more that we can get out there, the better. So people will start to see it more and be able to have conversations about it more.
There's no doubt that, and I know this from having experienced a level of joy that my Dr. Dixie experienced when she was going through something and read a book and then connected with the author, and the way in which she felt seen and heard was as good as the actual cure itself, right?
Yeah, absolutely.
Yeah, I mean, it's without a doubt so important to be seen and heard in all of this. And we still, in healthcare, and I was having a conversation with the managing director of a venture capital firm that specializes in serving underserved founders, underserved communities. And it was the first time that he has, I kind of like play between this desire to be very left of center about healthcare, right? And then be dragged into the business of healthcare, right? Because of the finance world that I participate in. And, I had met him for the first time, and he basically came out and said, we will never, ever be in a position to do the work that we need to do unless we recognize that to seek out a profit motive will always remove the ability for us to do right by our patient. And so I think that there's this interesting motive that we see in healthcare today, where people get super excited about ideas and innovation, yet we can't solve, like you're saying, we're not even solving some of the most pressing issues of our time because they don't get media attention, they don't get financed, they don't get praised, while there is some radically useless healthcare company in creating some type of AI-powered crap that is not solving an access issue, is not solving for providing precision medicine for women in a particular area that they've struggled with. And so until we get our eyes open about those types of issues, we're going to continue to struggle with this motive issue that is getting in the way of what you're talking about, because that's really what it comes down to. The bottom line is, if my motive is genuinely about serving people, like genuinely, like in my heart, like, like I am, bleeding about it, then my pocketbook and the modus operandi is going to change, and then I'm going to solve for those problems. But if my motive is profit only, right, in the healthcare space, then I will never be able to solve for the things that ultimately need to be solved for. We always tell people, Loxley Capital is not interested in solving an access issue for rich people, right? Like, they are already going to get care, right? So like, our job is to figure out how we take the most underserved, most vulnerable and marginalized communities in our nation and elevate them to a place where they're getting the best possible care that they deserve, simply because they're human and they have a breath in their lung.
Right.
We're not there. We're not in the 21st century. We're not there. And to your point, women's health is a perfect example of that. Like, we can, like, I joked about this telehealth company that's huge that does ED medication, right? And the billions of dollars that they poured into it for marketing, right? If they were to do that with women's health, then maybe I would believe the investment community actually has the motive that is necessary to be able to solve the problems of our day.
Right. Yeah.
Yeah. So there's that soapbox, I guess. I'm super passionate about it because I watch it. I watch it every single day.
Yeah.
I literally had somebody in the healthcare investment community a couple of days ago tell me that $35 million wasn't very much money. And I'm like, well, that solves for
it's crazy.
Poverty, starvation, and a whole lot of issues in most parts of the world. So if your worldview is that that's not enough money to get started, then you've got bigger issues, and you need a therapist. You do not need a VC. You do not need a private equity firm. You need a therapist and maybe a spiritual experience.
Yeah, absolutely.
So I obviously have a lot of experience in Ryan White, HIV/AIDS community. Been very active in it, both professionally and personally, as an activist. And I see Pep and Prep doing some incredible work, some really important work. I also see there being a certain portion of the community that has really taken Pep and Prep and used it as the excuse that's necessary to not necessarily be as healthy as they possibly could be.
Do you think that, are you seeing that a rise in other STIs because they're using PrEP, for example, for preventative?
Syphilis.
Yeah, syphilis has made a comeback. It's crazy. I've read about this.
I know. I had an education consultant which is basically just AKA person that places people at risk into treatment centers. And I said, yeah, I mean, the uptick, of the last, if you go back 12 months and then you count the 18 months before that, syphilis was up 75%.
Yeah, and
right?
that's another one that can be asymptomatic or the symptoms are when it's really progressed. So that's a problem.
Yeah, so that's a problem. And I'm trying to get there in a way that's not shaming, because the bottom line is that, there was a lot to celebrate with Pep and Prep, that people would be able to have sexual experiences like others, right? I mean, that was really what it came down to, is there was, that's something to celebrate for sure. But on the same token, we have to also, as clinicians, come back and say, all right, what's the byproduct? What's the unintended consequence of all of this? And how are we going to solve for that? So I was, really kind of curious about what you kind of heard, seen, and experienced around Pep and Prep just in general.
Yeah, I've seen that with where if people are on it, they're being less careful about other STIs. That's one. And then also, and I don't know what you're seeing. I mean, I still feel like the stigma's out there that it's only for, homosexual men, and it really, it's for everybody, and there has been an uptick with heterosexual, partners. And I read somewhere it was around like 20% of diagnoses, but it could even be more now. But I wondered what you're seeing also.
I would say that measurement is pretty close. Okay. I would say 20% is relative. Again, I'm working with a community that is at risk in multiple categories, right? So, I mean, 33% of the folks that come in that are IV drug users into one of our programs, they 33% of them have Hep C at a minimum.
Yeah.
Right.
And
so,
Hep C I'm seeing also as another one that's not really, I feel like it's never tested for unless you're an IV drug user, but that's a bad stigma too. Because if you're at risk for any other STI, you're still at risk for Hep C. And there's great drug treatment out there to basically cure it, which, I mean, why
absolutely.
Not get for it, and I think a lot of people don't know about that one either.
And there's financial, and so again, we come back to the reality of when pharma partners with other chronic disease organizations and hospitals and health systems and public health agencies, and budgets aren't being stripped, and we're being calculated about what we're doing in the public health world. I don't know that any of that's going to come to fruition right now, just because of the nature of what's happening. I don't want to get too political about it, but the bottom line is that, their budgets aren't going up. Public health agencies' budgets aren't going up right now. But what I would say is that the frustration, I think, in that community is that you think that you've simply solved for something when you really haven't. This is about the community that has been at risk for many, many years, and that community is still at risk. They're just at risk in different ways, right? And so, maybe I am not going to infect or be infected by HIV today, but I am my person, my lifestyle is on trial. So, all of those things are just as harmful and just as deadly and just as fatal. We've seen suicide rates skyrocket in the community in general. And so I think that, like, if you look at who we're serving, there's a reason why, our specialty, we have 4 very distinct specialties, because somebody comes in, they're 1 out of 3 times, they are a drug-related infectious disease case, they are a sexual health case, they are a psychiatric medication management case, and they are a harm reduction case. So we're ticking 4 boxes 33% of the time. It's number one, the reason why we're successful operationally. But, like, for instance, like, we do 80% of our revenue comes from Medicaid. So if Medicaid decides not to, not to pay us, then there are operational issues that we just have to face. But the reality is that behavioral health, both public and private, the way in which we deploy our resources, our capital, our services, it works, and we're able to service a lot of people and have success, where, like, normally, like, an independent pharmacy would go in and try and service a facility, and they're not going to have the financial success that's required, because they're not going to take care of the whole person all the time for the rest of their lives. But when we touch someone, over 52% of the time, we will see them through for anywhere from 5 to 10 years, right? Mm-hmm. So we have almost an intimate contract with that individual to take care of every aspect of their life from a pharmacy perspective. Yeah. And that, in my opinion, is what specialty pharmacy was always meant to be, was to be special. Right. And it's the way, and it's the way that we can be successful. But again, when we talk about, like, the other side of it, from a behavioral health perspective, and going back to stigma, we are facing in this, it just blows my mind that we are in 2025 and we are having the conversations that we're having, because it all ends up being about healthcare, right? Yeah. And when you talk about LGBTQ plus, gender affirming care, when you talk about disease states that are fatal, you talk about substance use disorder, and then you kind of put that all in a melting pot. It's easy to be attacked, right? It's also the reason why I am very vocal about kind of my journey, right? Because it's like, I'm the CEO of Mango Health. I'm the founder of an investment company that does these things. Mm-hmm. And the only reason why I'm doing them is because I was a patient once. Yeah, So I can defend for that, but a lot of people can't. Like, right. I have a defense. And so, but I think a lot of people are punished. Clinicians and patients are punished and are being punished right now simply because they want to live in a modern day society.
Yeah. There's a whole business of medicine, unfortunately.
Yeah, I'm never going to completely like it. I'm always going to participate in it at some level. And, it's one of those things where I try to play devil's advocate because the reality is it is 100% a business. It is the business of healthcare. But the question always comes back to, and there's a pediatric clinician, a pediatric doctor he's Brazilian. I don't know if you know, his name is Dr. Gabor Mate.
I don't know.
Anyways, he has really revolutionized the way in which we view addiction as being rooted in trauma. But he was the one that kind of said what I had reframed from that VC story, which is that it is absolutely fine for you as a clinician to be paid wonderfully well for doing really, really fantastic work. But as soon as you cross over into a profit motive, you are no longer servicing the patient or client. And so the question becomes, and I'll put this to you, what do we do to stop that? How do we in our small way defend for that? Because there's a righteous indignation that I have as a result of watching what seems to be pure turn into a motive that is not pure many, many, many times over.
Yeah, I mean, I feel like I don't know if there is a way around it at this point, as far as everything's profit driven, things are getting more expensive, people are not being able to afford treatment. I mean, I know sex therapy is not covered on insurance, so people have to self-pay for that, and it's a big challenge right now. I think the best way to handle it is just for people to know their own personal worth and what's the most important in prioritizing their health. And just trying to not focus so much on the money, because there's nothing we can do as clinicians as far as, our profession is dictated by her insurance company reimbursement now,
Right.
So it's hard to get around that. But the only thing you have to, as far as not getting frustrated with it, just remember what you're here for and why you went to school for this, and that you essentially want to help people.
Yeah. Yeah. I mean, it's without a doubt the most important perspective to have.
Yeah. For sure.
So to kind of start to maybe wrap this up a little bit, I think we went a little longer than I intended, but thank you for giving me your time. This has been a good conversation.
Yeah, absolutely.
I always realize something either about the topic or most of the time about myself, about how I really view the world, right? When I have these types of conversations. Talk to me a little bit about the challenges that you face when you're trying to ensure comfort for patients seeking sexual health services. What's the most important thing? What's your process for really bringing people into the fold and giving them hope?
Yeah, the most important thing is not treating them as a person. I like to get to know them, so then they can feel like they trust me. And it's interesting because I'll get a lot of couples, for example, and a woman's experiencing low libido, or, they'll do a session, they want to do a session together, a coaching session, or the woman will have her husband there, and I'll be like, I want to just talk to you, Mm-hmm. I think a lot of women feel like their partner has to be there. And sometimes I just want to have that conversation with them first, because they may not say things that they quite would normally if they were by themselves. So a lot of times I'll do a session with just a one-on-one, and then I'll do a couple session also. But that's a big one for me is knowing when I need to separate someone, if they're going in as partners in a session, because they may even say things that they wouldn't want to say in front of their partner, and that's important. And they may not have the guts to say, hey, I just want to meet with the therapist, or the coach. So I think that's a big one for sure, as far as my practice goes. And, just having empathy in general and hearing them out.
It's good. I'm dying to ask this question, and I know that there are a lot of folks, both male and female, that are going to hear this and they're going to be wondering, I wonder how she handles this, because it's got to come up a lot.
Mm-hmm.
How do you deal with couples that are struggling with the amount of sex that they're having in the course of a week? Now, I'm not going to make the assumption that it's the man that wants more sex than the woman. I think that that's the case quite a bit, but like, how do you address that? Like, what's the opening to diffusing that confrontational situation?
I think it's important to figure out first, what is their normal? What is their goal? So some people, like, we have this whole idea in our heads, like, oh, well, I'm only having sex with my partner once a week or 3 times a week or once a month. It's important to know what their goal is. I've worked with couples where they were just we got to them to the point where they were having sex once a week, but that was amazing for them. And that was all they wanted. So I think it's important to just everyone's a different case, where it's not like, okay, the average is 3 times a week. If you're not doing it 3 times a week, we need to get you up that number. It's not, it's about what is their goal? What's the end goal? And the biggest thing in the beginning is getting them to like each other, because sometimes they may just not even like each other anymore, or there's so many different things. Communication, is not there. But yeah, getting them on the same page as far as what's happening right now, what's your end goal? It's very simple. And then there's a lot of different things I go into, as far as I have them take the love language quiz to go over, what their love language is. And they'll often discover they didn't know that about their other partner. A lot of times, like
the Gary Chapman book, Love Language Quiz.
I like Dr. Laura Berman's one. She's a really well sex therapist. I really like her. So there's the 5 love languages. So I have them do a quiz. We talk about it in the next. I always give them homework. So we talk about it in the next session. We'll talk about what their love language is. And then also from a pharmacy standpoint, I always say and this is our first session too, when was your last doctor's appointment and when did you last have your labs done? Because that can be a lot of factors too. Even high cholesterol can cause low libido. So I go through all that, medications, labs, when was the last one done? So we can also rule out anything biological going on. And then the emotional aspect of it too. So there's 2 parts to that. And it really just depends on what their issue is, what they're going in for, and if it's a one-on-one session or not. So yeah, but those are the big ones. Yeah. Yeah.
I love that.
Yeah.
That's important.
Yeah.
Where are you located at? Where are you at right now? You sound like you're from New England.
I don't even know where I am. I work remotely as a pharmacist. I was born and raised in Rhode Island, went to school.
Rhode Island, okay.
Yeah. I live in most of the time in South Florida. I snowbird a lot. I travel a lot. But I actually did the sex therapy training in South Florida, which was pretty cool. It was a post-grad certification.
Cool.
So, yeah.
Cool. I'm in the Virgin Islands, so a little bit south of you.
Cool. That's awesome.
But when I'm not here, I'm in Boston. So
okay. Yeah.
I heard a New England twinge coming from you, so I just was curious.
Yeah. Yep.
That's good.
I still have my accent.
Yeah. No, I love it. I do. Well, this has been a super, super important conversation, super interesting. And so we close, I guess on a note a little less clinical and a little bit more human, although I think we've actually had a superhuman conversation today, a superhuman conversation. Yeah, I like that.
Mm-hmm.
I think it's important for our audience to remember that sexual health is not merely the absence of disease and dysfunction. It is the presence of awareness, integrity, and connection. It's where biology meets vulnerability, where pleasure meets responsibility, and where the soul quietly reminds the body You are sacred. To care for your sexual health is to ask, what does it mean to be whole? Well, it's a radical act of self-respect in a world that too often profits from our silence or our shame. So keep learning, keep listening, and keep reclaiming your narrative, because the most intimate form of freedom is the one where you are fully known, fully safe, and fully yourself. So until next time, may you walk with courage, speak with clarity, and love without apology. Thank you so much, Dr. Nadia.
Thank you. That was wonderful.
We'll have you on again soon.